Okay, thanks, Jack. Look, I thought you did very well. This is your first internal medicine term, and in second year, and so you hit a number of positives during your observed case examination. Your approach to the patient, your introduction, and your rapport with the patient was terrific. He felt comfortable with you, and you acknowledged parts of the history that were potentially distressing for the patient, like the passing of his mother, for example, so that was good to see. You started your history off with very open questions, which was good, but then you narrowed down quickly when you needed to get relevant negatives, and so it was good to hear you exploring the history of the presenting complaint. But then one of the things, and it was clear that this is a case of infectious diarrhoea, and what you then went on to do was to possible precipitants or predisposing factors, and so sick contact in this gentleman. And then you're also looking for signs of severity of his presentation. So you were asking about so you were asking about the number of times per day he was opening his bowels. Was there blood present? Was there nocturnal bowel motions? And so that's good to see. I thought you probably could, and then you sort of went on to also ask about his interaction with the medical system, went to Joondalup, what did they do, and how he actually came to Charles Gardner Hospital. That part of the history is often left out. You could have unpacked, I thought, in a little bit more detail the severity of his dehydration. So it sounded like clearly he was pretty sinkable and having significant dehydration. So it's someone with a kidney transplant, urine output, and things like that is really important. Electrolyte imbalance, does his creatinine actually go up? Have they been monitoring that? And so that was all good. There was some, I guess, other potential predisposing factors which would have been nice to hear about. Travel, for example, even though it's limited in the current environment with COVID. Had he been travelled to rural areas? Had he been on antibiotics? So specifically trying to target that Clostridium difficile. That's predominantly more diarrhoea than vomiting as well, but any new medications potentially pertinent. And then you went through his medical history in a reasonably methodical fashion. One thing I think you could have unpacked in greater detail is his kidney transplant, and so this is a major event in this guy's health history. And so really, why did he have the kidney transplant? What problem did he have to lead to that? And is that potentially still an issue for him affecting other parts of his health? So he may have had a multisystematic, he might have had a systemic disease which has affected his kidney, but also other parts of his body, which is of relevance ongoing now, or it could have been high blood pressure which has affected his kidney, which may well be of relevance now. And so there's kind of a gap, I think, in terms of that major medical event. And then what's happened after his kidney transplant? Has he had repeated hospitalisations related to infections with immune suppression? Has he had other complications? And so that could be unpacked in a little greater detail. And I guess, has he had previous bouts of gastroenteritis or diarrhoea? And if he has, then that increases the likelihood of alternative diagnoses. So just trying to get that longitudinal grade up in a little bit more detail. Now, coming to your examination, again, it was clear that you were familiar with the structure of the exam, and you did it very in a methodical fashion. You would have had good communication to the patient, so each step you were explaining what you were doing, so that was terrific to see. And your technique is reasonable. I think your interpretation is not quite there, and that just needs more practice. And so, for example, for the conclusion that there's fluid in the abdomen, you need to demonstrate shifting dullness. Well, I think you'd come to that conclusion before you'd actually turn the patient. So It's just the interpretation of what you're doing now just needs to be worked on, and that's an experience thing. And another thing, a technique point of view is when you are palpating the abdomen, particularly the deep palpation, it's important to look at the patient as well, just to make sure you're not causing them distress or discomfort. That's just a technique thing. With your your presentation, I thought that was fine. I think you did quite a reasonable job. Again, I think with the opening line, again, the relevant past medical history, which is a predisposing factor for infection and potentially of relevance to the severity of this presentation and ongoing management, is this kidney transplant and its immune suppression. And so whilst this is fairly hopefully a fairly simple case of infectious diarrhoea, it's complicated by the fact that you've had a kidney transplant. And so that should come out in that opening sentence. So 62-year-old mental health nurse that comes in with 13 days of diarrhoea, vomiting, and pre-syncope on the background of a previous renal transplant in 2018. And that gives a nice summary of the added complexity of the medical flavour of this gentleman, rather than just an acute diarrhoea, which should settle down and go away. Yeah. But overall, I thought that was a really good attempt.
Yeah, thank you.
Any questions at all?
No, that's all. Thank you.
Great. Thank you.
Hello. I thought I'd give some more feedback on Jack's performance, but totally agree with everything that Professor Adams has said. I would also like to thank Jack for putting himself out there and agreeing to make this video. I'm sure it wasn't easy. I'm also sure that most of you who have watched this video would agree that Jack did a whole bunch of great things during his SCA. He has a really nice manner about him and built rapport with the patient really easily. He started off with a wonderful introduction with a very clear explanation to the patient about the purpose of the interview so that the patient understood clearly what was going to happen. He also listened to what the patient was saying and acknowledged it, commenting in particular on distressing events that occurred in his life. Jack has a very good structure to his history taking with great detail on the social aspects of the patient's story and provided a nice summary back to the patient near the end to confirm its accuracy. This is a really powerful technique to introduce into your history taking. Jack has also clearly got a very strong knowledge base, especially considering how early in his medical career that he's at. The key question, though, for the purposes of this teaching video is what could Jack have done to improve his performance? You need to remember that what we are assessing and what we are wanting the student to develop is a set of skills. In this instance, the skill is history taking, examination, and formulation. Embedded within this is the concept of critical thinking or clinical reasoning. To enhance this, I can think of two key broad things that Jack could have done better, and Professor Adams touched on these in his feedback, but I wanted to emphasize it a bit more here. Firstly, there could have been more critical thinking put into what the cause of the presenting complaint may have been. In this case, the presenting complaint was diarrhoea, and I can think of, broadly speaking, two major causes of diarrhoea, that is, infective causes and non-infective causes. The patient provides a highly plausible explanation for the infective diarrhoea being caused by his grandchild, who is also recently unwell. However, as doctors, we need to be more critical and not simply accept a patient's explanation of things as they may be unwittingly misleading us. What other causes can you think of? I can think of food poisoning, antibiotic-associated diarrhea, as Professor Adams suggested, and then I can think of non-infective causes such as malabsorption, inflammatory bowel disease, or adverse reactions to medications, just to name a few. So if you're taking history to support or refute some of these differential diagnoses, you may want to find out if the patient had recently been taking any takeaway or eaten something that had been in the fridge for a long time. Or maybe if you're considering inflammatory bowel disease, on top of the history that Jack elicited about mucus and blood in the stools, you may have wanted to find out if the diarrhea was recurrent, if there was any associated weight loss, or any perianal symptoms, just to name a few of the history questions you could elicit. The second broad thing that could have been improved is the detail of the patient's other medical problems. This is important for two major reasons. One, you need to be confident that you can manage all of the problems that a patient has, not just their presenting complaint. You need to imagine that if you were the only doctor looking after the patient in front of you, could you manage all aspects of their health? So in this case, how long did the patient have hypertension for? What treatment have they had for their hypertension in the past? And what is the control of their hypertension like now? Same for every medical problem, such as the kidney transplant. Why did he have kidney failure? What treatments has he had for his kidney failure? When was his transplant? What complication has he had from his transplant? What is the function of the kidney like at the moment? And so on. The second major reason for obtaining more detail about the patient's other medical problems is that it may influence the presenting complaint. In this case, it could influence a differential diagnosis. For example, kidney transplant patients can get CMV disease, which can present with GI symptoms such as diarrhea. Also, these other medical problems may be affected by the presenting complaint. So in this case, you'll be concerned about the transplant not working properly in the context of the diarrheal illness and associated diarrhea and associated dehydration. Having said that, Jack did really well, and Professor Adams later on off camera said that he would have given him an 8 out of 10, which is probably around about what I would have given him too. Hopefully, these two episodes have helped you understand what we are trying to teach a little bit better. Please like or dislike below if you feel like it, and provide some feedback in the comment section so that we know if these are any good and what future videos you may want us to develop. In the next couple of episodes, you'll see a more senior medical student performing the same assessments so that you can have an idea of the skills that we are trying to develop in all of you. See you later.